Hello. Today we are going to be talking about pre-transfusion testing. This includes type, screen, and crossmatch. Why do we do pre-transfusion testing? To select the best possible blood or blood products so that when they're transfused, they'll have an acceptable survival rate and they will not cause harm to the recipient. So the minimum requirements as far as AABB standards, on the transfusion request, you must have enough information for a positive ID of the intended recipient. And on the blood sample itself, you also must have positive ID. And you want those two to match. Whatever is on the request needs to match what's on the tube itself. For a positive ID, you need two identifiers. Those can be name, date of birth, name, social security number, name, medrec. You also must review your previous transfusion records. So most hospitals will have a computer record. Some reference labs may have a computer or a paper record or a mix of both, but you want to try to find any relevant information, like if this patient has had antibodies in the past. In addition to those items, the donor blood also must be retyped by the transfusion service. So if they're ordering blood from a blood center, when they receive it, they must confirm the ABO type. And if the D type is negative, they must also confirm the negative part. If they ordered positive blood, so if it's A pos, they have to retype the A, but they don't have to confirm that it's positive. So once you get the recipient blood, you need to do your ABO group, your RH type, which is really just the D type, and you need to do an antibody screen to detect any unexpected antibodies. When we say unexpected, that means non-ABO antibodies. We expect the patient to have ABO antibodies unless they're AB. Once we have the type and the screen, we will be able to select compatible blood components. Depending on where you're at, the crossmatch may be serological or it may be an electronic crossmatch. Then you will have to label the crossmatched blood, and then you will need to, before you release the blood to the floor or whoever's going to transfuse it, you'll need to inspect it at issue. On that request form, you must have the minimum information for positive ID. So you must have the recipient's complete first and last name and a unique ID number. So like I mentioned before, it can be social security, it can be medrec, or it can be date of birth sometimes. You also must have a physician's name. No test can be performed without a physician's order. So that is not optional. Before we do any testing, we have to make sure a physician has actually ordered the test. So you can include any additional information like age, date of birth, sex, race. Those may be helpful, but those are not necessary. And then patient location. If you're in a hospital, it may have the room number. For the collection itself, the patient must be positively identified. So each facility will have a different SOP for how to do this. Usually, the phlebotomist will walk into the room and ask the patient to state their name and date of birth, or name and some other identifier. The blood samples must have that information on the tube, and that tube needs to be labeled before they walk away from the patient. The person collecting the blood must also date, initial, and put the time that the blood was drawn. And when the transfusion service receives that sample, they need to confirm that all that information is accurate. And usually they do that by comparing it to the request form. In the past, most blood bank testing was performed on serum. Now it's really not used at all in the blood bank. Usually the blood bank will only get a pink or purple top EDTA tube. Usually we don't see serum at all in the blood bank. So each test will have a package insert that will say what samples are acceptable. Most manufacturers will only validate EDTA tubes. So you need to check if you do get a citrate or an ACD tube, that is plasma, but it may have not been validated for that test that you're running. We also want to try not to use hemolyzed samples. Hemolysis is a sign that there can be some antibody interaction happening. So if we do have to use a hemolyzed sample, we want to make sure to use autocontrol so that you can compare the autocontrol to the actual screen or test that you're running. The antibodies that may cause hemolysis are ABO antibodies, the P blood group system, Lewis, KID, and Bell. Compatibility samples are only good for 3 days after collection, and typically you want to try to cross-match only up to 3 days before the transfusion, because if the patient's in the hospital, there might be something going on where they could be developing antibodies or something could change. So you want a recent sample so that you have a recent picture of what's going on in the patient. If the recipient has been transfused in the last 3 months, they might be developing antibodies, or if the recipient has been pregnant within the last 3 months, they might be developing antibodies as well. There are some situations in hospitals where they might extend that date for surgeries, future surgeries, so that they have time to find compatible blood if needed. Sometimes you'll find the patient has an antibody, and it might be a rare antibody, so they might have to do a nationwide search for that rare blood. So you want to try to get the antibody picture as soon as possible. So some hospitals will have a policy that says the cross-match is acceptable for up to 7 days. So you want to retain that recipient sample for a minimum of 7 days after transfusion. And you want to retain one segment from the donor bag, at least up to 7 days after transfusion. And that's just in case there's a delayed transfusion reaction. You have that sample from the recipient and the sample from the blood so that you can do some tests to see if there was an error performed during the compatibility testing. ABO confirmations. Whenever the hospital orders a blood order from a blood center, typically they'll put in an order for 10 O negs, 10 A pos, and so on. The hospital will receive a box full of all their blood that they ordered, and when they receive it, they will confirm the ABO of all the units they received. The RH typing or D typing, they only need to confirm the negative units. The D positive units, you already know it's positive, so you don't need to confirm that it's positive. Okay, once that recipient sample is received, you will do an ABO type, an RH type, which remember, when we say RH type here, we're talking about D type only. If you remember, the RH has something like 52 antigens, so RH type is very extensive. So in common talk, when you say RH, you just mean D. Or even once we say a full RH serology, we're just talking about the common RHs, which are D, big C, little c, big E, little e. But usually we're only doing D typing. And weak D testing is not required by AABB for pre-transfusion testing. We will talk more about weak D testing when we get to the prenatal testing. And a D control is required whenever you do weak D testing. Okay. You also need to do an antibody screen to detect any unexpected antibodies to red cell antigens. So the standard states Methods of testing shall be those that demonstrate clinically significant antibodies. They shall include an incubation at 37 degrees Celsius, preceding an antiglobulin test using reagent red cells that are not pooled. The not pooled is significant because when we do the testing of the donor units, we can use pooled cells, but you cannot use pooled cells on patient testing. So some hospitals will use a 2-cell screen. Most will use a 3-cell screen. The FDA mandates what antigens are required on screen cells in order to detect all those clinically significant antibodies. Those are the common Rh antigens, M, N, big S, little s, Kel1, Kel2, Duffy A, Duffy B, JKA, JKB, Lewis A, Lewis B, and P1. So these are anagrams. These are received with any screen or panel that you get from a manufacturer. So different manufacturers will have different things on their anagrams. Some have lots of useful extra information, but they should always include the lot number, the expiration date, and then the antigens present on each cell. So some will have them labeled, like on the left, they'll say cell number or they'll say vial number. So each vial or each cell is one donor. So this is telling you what antigens are present on that donor. So donor 1 is positive for D, donor 3 is negative for D. So once you test the patient, you can, well, one thing you will see if they have antibodies or not. If they don't have any unexpected antibodies, then you should get an all 0 reaction, so no reactions with these cells. Another thing is all screening cells are O, and that is because you don't want to deal with any expected antibody reactions. If you use an A donor, then an O patient would be reactive to it. So you don't want to have any non-significant reactions. And this is typically what you will see for reading on the screen. So you will record your reactions as 4+, 3+, 2+, 1+, 0. Some people will put an M for a microscopic reaction. Some people will put a W if it's a very weak reaction. And then you also want to record all the phases that you're reading it at. So you would record immediate spin, 37, and also what technology. So if you're using gel, you'd write gel. If you're doing a tube test, your anti-human globulin phase, some people will write IAT for indirect anti-globulin test. IgG, which is really anti-IgG, but it just is different at each facility. So you might see it all different ways, but usually it'll be one of these for the AHG phase. Also, anytime you do anything special, you want to record the temperature or the time so that whenever someone's reviewing the report or the reactions, they'll know what you did. So if you are trying to look for a cold antibody, you can incubate at room temp or 4 degrees. So you want to record how long. So typically it's recorded like this, 4 degrees Celsius for 15 minutes or room temp for 30 minutes. And then if you use any like a Fison treated panel, or you use LIS or PEG, any enhancements, you want to record that as well. So here's an example of an antibody screen. You can see the phase of the reaction, immediate spin, and then PEG AHG. So PEG is the enhancement material that we're using, and then there's a positive reaction. So they also did further testing with DTT and Fison and listed the results there. You'll see down here you have your 3 screen cells, and then you have your patient cells. This is called the auto control. You want to do this at each phase, and if you use any special enhancements or treated cells, so that you know how it's affecting the patient cells as well. You also will interpret the screen as positive, negative, or inconclusive. So this one has a reaction, so it would be positive. If everything was 0, no reactions, then it would be negative. So different hospitals or facilities will name the test differently. For a blood type, they might say blood type, ABO-RH, ABO-D. The interpretation should include the ABO type and the D type. So you'll have AB positive, AB negative, or whatever. If it is a ABO discrepancy and your facility doesn't have the means to investigate enough to be able to resolve the ABO discrepancy, then you would report it as inconclusive. The screen would be just interpreted as negative, positive, or inconclusive. You're not expected to make an antibody ID just based on a screen. You don't have enough information at that point. You'd have to actually do an antibody workup, do further testing. So if you were doing the antibody ID, you would complete the workup until you could actually determine what the antibody is. And then the interpretation would be the actual antibody, such as anti-C, anti-big K, or whatever the antibody is. When you're ordering a crossmatch or a compatibility test, the result should be compatible or incompatible. You're testing against a particular unit. So you're saying the patient is compatible with this unit or incompatible with this unit. So you want to make sure you have the right terminology. You don't want to say a crossmatch is negative. You want to say a crossmatch is compatible. And likewise, you want to say a screen is compatible. A screen is negative or positive. So here's another example. A type and screen are ordered on a patient. The ABO and D and a gel screen are performed. The results are here. So anti-A and anti-B are negative, and we have a reaction with the reverse cells, so that's a straightforward O. Then our anti-D is positive, our control is negative, like it should be, so we have a straightforward O pos. Then our screen has some reactions, so the screen is positive. So then we would do further testing to actually ID what antibody is present. So an auto control is when you test the recipient's or the patient's red cells with the recipient's plasma. This is not required, but it is helpful when you're doing the antibody ID. When you have all positive reactions with your screen or panel and you run an auto control, that can help determine if it's an auto antibody or an allo antibody. So usually when you get a positive screen, or you have an ABO discrepancy, or you have a hemolysis sample, you'll run an auto control. For your historical record check, you want to compare your current results with your historical results. For example, if you have an O positive mother and you check her record and she was O negative in the past, you need to investigate that finding. Do you have the wrong patient file? Was your current testing correct? You may need to retest some things to make sure that you have a correct sample, that there wasn't a tube mismatch. Okay, so when we're selecting compatible units, we want to make sure the red cells are compatible with the recipient's plasma antibodies. We don't want the recipient's antibodies to destroy the red cells as soon as they're transfused and cause a hemolytic transfusion reaction. So in the case of whole blood, you want to do ABO identical because you want the red cells and the antibodies to match. Unfortunately, usually whole blood is used in trauma situations where you don't have a blood type yet, but if you do have a blood type, you want to use ABO identical. If you're selecting for red cells, if the recipient is O you want to choose an O because that recipient has anti-A and anti-B. So if they're transfused with an A or B unit, those antibodies are going to bind to those red cells. For the Rh or D type, if you have a D positive patient, they can receive D positive or D negative. You don't want to give D negative unless that's the only thing you have available, because you want to save those D negative units for the D negative patients that actually need D negative. So D negative recipients can only get D negative. The caveat to this is if there's a trauma and it's a woman older than childbearing age or a male, sometimes they will be given D positive units if D negative is in short supply. If a patient has clinically significant antibodies or a history of antibodies, the blood given, whole blood or RBCs, must lack that antigen. So if a patient has an anti-big E, the unit must be big E negative. So when we're selecting for plasma or FFP, the FFP must be compatible with the recipient's ABO antigens. Remember that FFP has the antibodies from the donor. So if the recipient is O, they can get an O unit. But if the recipient is AB, they have A and B antigens on their cells. So you don't want to give them O plasma because that O plasma has anti-A and anti-B in it. So it will attack the recipient's red blood cells. You do not have to cross-match for FFP. Typically, we only cross-match for any component that has RBCs present. So for platelets or cryo selection, you try to do ABO identical, but if that's not available, you would use the alternative type based on plasma compatibility. If the platelet unit is collected by apheresis and contains more than 5 mils, a cross-match would be required. 5 mils in a platelet product would make it look very bloody, and we are usually in a platelet shortage, but usually these units would just be discarded because most hospitals would not accept them. So here's a chart for platelets. You'd select in this order. So the D type does not matter for plasma or platelets. You can transfuse if the patient is D negative, you can transfuse D positive platelets. Platelets do not have Rh antigens, so an antibody to D would not affect the platelet life. So what is the purpose of cross-match testing? You want to check the serologic compatibility between the patient and the donor. We mostly only perform major cross-matches now. You might read about minor cross-matches in a textbook, but they are typically not performed at all. So when someone says cross-match, it is a major cross-match that you're performing. And that is when you're testing the patient plasma with the donor red cells. So the donor will have little segments attached. You will take a segment off and then perform compatibility testing with the patient plasma and the donor RBCs. You must also do a cross-match in anything that has red cells, so whole blood, red cells. Granulocytes also have a lot of red cells, and like we discussed on the earlier slide, if a platelet was bloody looking, you would have to do a cross-match for that too. If a patient has no clinically significant antibodies and there's no record of previous antibodies, you only need to do an immediate spin cross-match. And this is to detect ABO incompatibility, to make sure that you grab the right unit off the shelf. If you grabbed an incompatible ABO unit, you would see a reaction at immediate spin. The extended, or sometimes called full Coombs or AHG crossmatch, you must do when there is an antibody present, or there's any history of antibody, or if there's an ABO discrepancy, a transfusion reaction, and sometimes if for trauma transfusions, if they will get units before they have an ABO type, they might do the full crossmatch afterwards to make sure everything is compatible. So the minor crossmatch, just so you know the history, it's the opposite. It's testing the recipient cells with the donor plasma. So it could be helpful in FFP transfusions or hemolytic transfusion reaction workups, but it's not typically performed. I don't think I've ever seen anyone perform one. So we'll go through some crossmatch possibilities. If your antibody screen is negative and your crossmatch is compatible, usually that unit is compatible, but it does not necessarily guarantee that an antibody is not present. There are low-frequency antigens that all screen cells do not have one of those antigens present. So a patient could make an antibody to a low-frequency antigen, and it shouldn't cause any problems if the crossmatch is compatible. So if you have a positive screen, you know that there's antibodies present. The crossmatch is incompatible. That can be caused by allo antibodies, auto antibodies. It could just be rouleau, or it could be a reagent-related antibody. Sometimes we have patients have antibodies to the preservative that's in screen cells, or to the anticoagulant that's in the donor unit. So it may not be a harmful antibody to the red cells. It might just be to the reagent. So if you have a negative antibody screen and an incompatible crossmatch, again, that could be an antibody to a low-frequency antigen that wasn't picked up on the antibody screen. You could have selected the wrong ABO donor unit. That donor unit could have a positive DAT. Your patient could have an anti-A1 if they're A subgroup. It could be an antibody that wasn't picked up during the screen because it's showing dosage, and that unit might happen to have a double dosage, so now it's showing incompatible. Or it could be passive antibody if the patient's been getting a lot of plasma or platelet transfusions. It could be those donor antibodies that are passively circulating in the patient's blood and causing an incompatible crossmatch. So there is such thing as an electronic crossmatch. This is when a computer determines the appropriate match between the recipient and donor. You must perform an ABO and D and antibody screen before you do an electronic crossmatch, and you can only perform one if the recipient doesn't have antibodies or they have never had antibodies. And also, if they have a typing discrepancy, you cannot perform an electronic crossmatch. The computer really is only looking at ABO compatibility. These software have to go through rigorous validations before these can be used, because ABO compatibility is extremely important in selecting a unit for transfusion. So you also must have 2 ABO tests on file for the recipient. You can use a current sample if there's a historical ABO on file, or you can do a current sample and then recollect a second sample. They have to be 2 different draws, so at a different time or a different phlebotomist. Or if the software is validated for positive ID, they can use the same sample. But to be the safest, it's best to have 2 different draws. And this is because one person can make a mistake. If they label one tube wrong and you give an ABO mismatch to a patient, you could kill a patient. So it's always safest to have two completely separate draws so that you know you would find something if one of the tubes was mislabeled. So in order to perform an electronic crossmatch, computer validation and testing is required. A method must exist to verify correct data entry prior to release of blood and blood products. The system must also be able to alert the user of any discrepancies between the donor unit and the blood group confirmatory test. So when the transfusion service labels a unit for transfusion, the tag must be attached securely to the donor unit, and the label must have the following information: patient's first and last name, ID number, unit number, expiration date, interpretation of crossmatch, the initial of the person completing testing, and the ABO and D types of the recipient and the donor, and the date of the testing. So at the time of issue, that donor unit must be inspected. You want to look for any abnormality, a color change, bubbles. Sometimes if a unit has bacterial contamination, that'll cause strange colors or bubbling. Also any leaks or leaking ports. If something is leaking, the sterility is compromised. So at issue, you must compare the donor unit with the tag. You want to make sure the expiration dates match, the blood types, what component it is, make sure that the donor type is compatible with the recipient type, and that the unit is labeled appropriately. You must document the name of the person issuing the unit from the blood bank and the person picking up the unit. And you have to verify the intended recipient. So the blood order request patient name and medical record must be verified. So what happens when a nurse picks up an RBC unit, takes it back to the floor, and she finds out the patient was released from the hospital before she was able to transfuse the unit? Those units can be returned to the blood bank as long as the component has not expired, the closure has not been disturbed, the red cell components have not been warmed above 10 degrees, and the lab records must indicate that the unit has been returned and later reissued. That nurse can't say, oh, well, my other patient needs blood, so I'll just take this unit down to them. It has to go back to the blood bank, and they have to retag it for that other patient. And one sealed segment always has to be attached to the unit. We'll talk a little bit about neonatal transfusions. So there are special rules for infants less than 4 months of age. And that is because they are not making their own antibodies yet. Any antibodies that are circulating through baby are the mother's antibodies. So we only do forward ABO typing. We don't want to do reverse because those are mom's antibodies, not baby's. You do want to do RHD, and you want to include weak D testing if the mother is Rh negative. If the mother is D positive, you do not have to do weak D testing. You can do an antibody screen from plasma of the infant or the mother because they're basically the same thing. If you have to do a crossmatch, a positive antibody screen indicates that there is an antibody present, which is the mother's antibody. So you would have to do an AHG or extended crossmatch. If you have a negative crossmatch or a negative screen, you do not have to do an extended crossmatch. But the screen and the crossmatch can be done from the infant or the mother's plasma. Once the initial ABO and screen is performed, you don't have to do any repeat testing for the remainder of the infant's hospital stay or until they reach 4 months. So if it is a baby that's going to be in the hospital longer than 4 months, at 4 months you have to start retesting. Also, if the infant is released from the hospital and then they have an accident and they have to be readmitted to the hospital, you would have to repeat all the testing. So Group O infants should receive Group O RBCs. If you are a non-Group O, they should be tested for passive ABO antibodies to see how much of the mom's antibodies are circulating. And you would do this through AHG phase. If the antibodies are detected, the infant should be transfused RBCs lacking that corresponding antigen. For massive or large exchange transfusions, you should give sickle-negative blood and CMV safe or negative units. In the past, all units were not leukoreduced, so babies would get CMV negative blood, but now CMV is carried in white blood cells, so now that all units are leukoreduced is considered CMV safe. Those units should not carry any CMV. And CMV is a very common virus that most people are positive for. It doesn't cause any issues unless you're immunocompromised. Moving on to emergency release blood. If blood is released prior to completion of all the pre-transfusion testing, a signed statement by the doctor has to be released before issuing that blood. So that is non-cross-matched blood. Anytime a doctor cannot wait for the testing to be done, they must sign out that blood. So you'll see this a lot in trauma hospitals for car accidents or gunshot wounds. If there's no type available or the victim might be unknown, so we might have a previous history on this patient, but the patient hasn't been ID'd. We will issue O RBCs. We will try to get a sample as soon as possible so that we can complete the testing as soon as we have that tube available. And that unit must be labeled as non-cross-matched. So for those emergency situations, we try to use D-positive blood for males and also for women beyond childbearing years. The only problem is those women may be D negative and they may have had a baby which may have induced an anti-D. So there is some risk there. So usually hospitals will try to be as conservative as possible and only issue to males, but sometimes there's just not any D negative blood. And the saying goes, you're either going to have a transfusion reaction or you're going to bleed out. You'd rather have a transfusion reaction, more likely to survive that. So in cases of massive transfusions, the definition of a massive transfusion is when you infuse a volume of blood approximately the recipient's total blood volume within a 24-hour period. So this could be a very traumatic surgery where the patient is continuously bleeding and they're continuously being transfused, or a car accident where they bled a lot and they were just giving O negative emergency release. At that point, the blood is no longer representative of what's in the patient or the patient's original blood type. So, if they're given O negative units, 20 O negative units, and then you draw a sample, you're mostly getting donor blood at that point. You're not getting the patient's blood. So at that point, you don't need to do an extended cross-match. You would perform ABO, immediate spin cross-matches, until that patient has had some time to recover and starts replacing the donor RBCs with their own. So record keeping is extremely important. There's the saying, if you don't document it, it didn't happen. You have to record everything you do, because in 2 years when you get inspected, or in 2 months when they're investigating a transfusion reaction and they say, why did you issue this unit? I don't see compatibility testing. And you think, oh, I know I did it, but I didn't record it. If you don't document it, it didn't happen. You have to be able to trace any unit of blood from its source all the way to the recipient. So from the time it's drawn at collection through the donor center, all the disease testing, all the testing the donor center does on it, from the time it is transported to the hospital receives it, they do their ABO confirmation, they do their compatibility testing with the recipient, and then they issue it to the floor. The floor, whenever they transfuse it, everything is documented every step of the way so that you know exactly who did what to that unit of blood. So you always have to make sure you keep records of quality control, testing, storage, transportation, everything. So record keeping is highly regulated and everyone has different rules. Sometimes the state rules will be more conservative than the federal rules. You always have to go with the most conservative standard. So when you have recipient consent, you have to retain that record for 5 years. Any previous history, you have to retain for 5 years. ABO and antibody records, you have to retain 10 years. If there's any difficulty in typing or clinically significant antibodies, you have to retain that indefinitely. And transfusion records, including the vitals taken at transfusion, are retained a minimum of 10 years. Transfusion committees are required by AABB, CAP, and the Joint Commission. Usually this committee is comprised of physicians, surgeons, nurses. If the hospital has an education department, there's a risk management department. If there's pathologists available, blood bank medical director, and sometimes blood bank staff like supervisor or manager may be on that committee. So the purpose of this committee, they must meet at least quarterly, and they want to review everything related to transfusion. So the transfusion practices, the cross-match to transfusion ratio. So you want to know, are you cross-matching 100 units and only 2 get transfused? So that's a lot of extra work for the blood bank. What kind of blood wastage? Like, are the nurses picking up the units and then they're sitting on the floor and not getting transfused, and then they have to be discarded because there's always blood shortages. So we really, really want to be good stewards of the blood supply. How many mislabeled specimens were there? How many incident reports were there? Any quality issues that may have delayed service, that patient getting a transfusion, or any kind of delay in service. And then any kind of hospital or laboratory issues. Basically, you just want to make sure everything is moving smoothly and you're wasting as little as possible. That is all I have. If you have any questions, please let me know.